Hello, my name is Nikila Rawal. I am a pediatric otolaryngologist at Children's Healthcare of Atlanta and Emory University. Today, I will be discussing our study entitled Intensive Outpatient Programs for Pediatric Feeding Disorder, a qualitative study of current challenges and future directions. Pediatric feeding disorder, defined as impaired oral intake that is not age-appropriate and is associated with medical, nutritional, feeding skill, and/or psychosocial dysfunction, is rising in prevalence and is estimated to occur in about 25% of the general pediatric population. For children with avoidant restrictive food intake disorder, which is also known as the psychosocial component of pediatric feeding disorder, intensive multidisciplinary intervention has been shown to be effective, with treatment resulting in improved oral intake, mealtime behaviors, and caregiver stress. IMI, which often includes psychologists, physicians, dietitians, and feeding technicians, allows for careful delivery of therapeutic meals, introduction of new food types and textures, reduction of enteral nutrition, detailed monitoring of feeding progress and complications, and/or other services specific to the patient's needs. However, despite the proven effectiveness of IMI, there is a dearth of programs providing the service across the country. Therefore, we sought to answer two primary research questions with our study. How do leaders describe the barriers faced by intensive multidisciplinary feeding day programs, disparities in patient care, and challenges regarding assessment, diagnosis, and treatment for pediatric feeding disorder? And secondly, what perspectives do leaders have on necessary future directions for their programs? In order to answer these research questions, our team conducted a qualitative content analysis. We utilized semi-structured, open-ended interviews with program directors of IMI programs via the Zoom platform. Following interviews, transcripts were coded using an open coding approach with constant comparison analysis. Through a combined inductive and deductive approach, a composite codebook was generated with input from 4 coders who all individually coded the first 4 interviews. The composite codebook was then used to code 2 more interviews with all 4 coders. Once consensus was confirmed, the remaining interviews were divided amongst coders and the first 4 interviews were recoded using the composite codebook. Our study team ensured adherence to principles of intercoder reliability as well as trustworthiness and rigor throughout the process. Our findings reveal that the majority of programs that were included were opened in the early 2000s. The Midwest had the greatest number of programs, though it is worth noting that inclusion of only outpatient programs resulted in exclusion of other types of programs with an inpatient model that treat PFD. This may explain why certain regions had less representation than others. From the qualitative analysis, we were able to identify 3 primary themes related to barriers to care. These were patient-level factors, program-level factors, and system-level factors. Program directors noted various specific points at the patient level that created barriers. One said, with regards to family-related barriers, we also had a few kids who come from very large families, and just the family dynamics and the parental commitment to being here was just very hard. Transportation was also noted to be a problem, with one program director stating, "We have some that have some challenges with vehicles, and being able to travel here, most of them from a distance away, would stay at the Ronald McDonald House, which is just like a block away, but sometimes it's just the transportation." At the program level, one program director reported, because families can't self-refer, that's also a barrier because they may recognize their child has a feeding problem, but if they can't convince their provider that the child has a feeding problem, they also don't get referred. This was part of the issue with access. At the system level, issues with insurance reimbursement were noted to be a significant barriers to getting patients into IMI. Program directors also shared their thoughts on their own goals and ideas for future directions to tackle some of these barriers. This included a consensus on classification of PFD to improve referrals, increased education about PFD and the treatment, improved access in programming, and improved and standardized evaluation of outcomes. Looking to the future, we believe that improved standardization of the treatment and delivery of care can help improve access and outcomes. One way to do this is to develop an American Medical Association code, which can lead to improved reimbursement with subsequent improved resource allocation and program proliferation. Further, the development of a consensus statement on the structure and function of IMI programs would aid those institutions trying to start their own IMI program to improve access. Lastly, more comparative effectiveness research for various IMIs can help optimize both treatment and outcomes.